Regulation at the federal level is in flux. I don't think anybody here would argue with that. We've heard lots of references to that about executive orders that have been reversed from the Biden administration with guardrails for AI. And we've seen big tech, withdraw pretty significantly in moderating content online as well. So there's a lot of questions on the federal area of what are the regulations in AI and what will the future regulations be in AI. But that's at the federal level. So I'm kind of excited that we have a representative on the state level because probably people don't know this, but last year, 46 states passed 238 pieces of legislation on technology, all of them including AI. So that's a lot of activity, folks. Somebody, it may have been David Heenan or someone else said, what do we do when all these states are legislating their own way? You may have said it, Matt. And then people start copycatting it, or they're very different. So let's start with you, Zach, and say, what role does the state have now that the federal level has left a hole in regulation over AI?
Well, first, thank you for having me. Thank you for everyone, all that have said how nice my bow tie is. Generally, when I'm in the AI tech space, like an RTP, I take it off. So thank you for the encouragement. But always glad to be a part of these types of discussions because we believe in North Carolina that this is the future. These types of convenings need to be celebrated. They need to be shared across the country because I believe North Carolina can be the best state in the country for this. I think we have what it takes, incredible universities, but it does have, we have to include government in the conversation. And so I really believe that, our role and what most states should do, because we, as previously mentioned, in the early days when AI sort of first hit the scene 2 or 3 years ago, everybody wanted to restrict, take away. And so what we are trying to do in North Carolina is convene. We want to make sure that we're bringing together sectors to chat about a responsible path forward for innovation. Because North Carolina is an innovative place. But most importantly, understanding. I don't know if you know it, but legislators don't know a lot. They do. They know a ton, but they don't know what they don't know. And we don't want people making decisions about things that they're not aware of, right? We want to make sure that they're educated as they're making decisions because they have widespread implications. In North Carolina, we don't believe that we have to be afraid of what we don't understand. Right? We just need to bring the right people to the table to make that happen. One thing that is probably similar to what you have heard from around the country is that we do want to know and bring together folks to understand the impacts on society, especially children, and the potential for impacts on patients and healthcare, right, and education. And so, those are things that are on our minds, but that's the way that we're approaching it in North Carolina. We really need to take a path of understanding, bringing people together, coming up with a path that can, have the most impact for the state. North Carolina is number 9 in U.S. population, and over the next 2 decades, we'll go to number 7. This place will grow. It will be driven by Charlotte. It will be driven by the Triangle and our universities. And so we have a responsibility with all those people who will be coming here for jobs to create and amazing opportunities for him. And so what I'll end with is that we don't have to be a barrier. State governments don't have to be a barrier to the work that you're doing. We can be a partner. And so I see that lots of other states have started to get that way, but now that North Carolina is jumping in with both feet, we want to make sure that partnership and collaboration is the name of the game.
States should be regulating AI. Federal level is not active.
No, I don't think state. I don't know if I have strong opinions about that. I do think right now there's more of an issue in healthcare where integrating AI is actually incredibly difficult, and we're not seeing too many use cases from what I'm observing on the engineering side. I'm not representing the engineering side, but just due to how complex HIPAA architecture has to be and PHI information, we're finding it hard to build it inside the workflows of our healthcare customers. I'm obsessed with this one company called Sully AI, and it's not because it's similar to my last name, but it's because they are doing a pretty good job starting on more administrative tasks like had a couple of notes here. It was, they were providing like an AI agent that's a scribe or a receptionist or a medical assistant. And that seems like low hanging fruit of a way to start. So, not worried as much about guardrails. I do think the solution to guardrails is open source things. I think Meta did a great job of doing that with their models. They open sourced everything and it kind of turned the whole industry on its head. And I think OpenAI mentioned that they felt like they were on the wrong side of things by keeping it behind this veil. But I think really it's more about like how do you actually integrate AI safely into existing workflows and patient data, and how do you de-identify it? And it's causing startups to have to raise a ton of capital for these really massive infrastructures and architectures. So it's more about like let's find the applications first and then find a safe way to do it.
Scott, you are a prolific researcher investigating AI-driven decision-making. Do you think there should be more regulation in this space? Are you at all concerned with this sort of an unfettered playground?
Thanks, Christy. I appreciate it. The answers that both Zach and James, almost said Justin, James gave, I'll piggyback a little bit off of. I don't think there needs to be additional regulation, but I think cross-state interoperability is definitely an area where we need to lean in heavily in the absence of federal regulation. When it comes to AI policy, you pointed it out, the sheer volume of what we've done in the past few years, is an obvious area where I think you're going to see some growth. From a research standpoint, if I'm prolific, I guess I am. Thank you for that. I am researching AI-driven healthcare decision-making actively. And in the past 2 publication years, 23 and 24 alone, we've had over 150 publications. My students and I have dug into about 87 of them so far. So there's quite a bit of opportunity in the private sector for that regulatory body to develop, as we point out here. So state working with private, I think, is really the right answer. If the Fed's not going to do something on their own, which is going to be an interesting conversation in and of itself. Meta is a good example. Meta's in Louisiana as of this year. Being from University of New Orleans, we're trying to lean in there, and the state is actively taking participation in some of those areas. So without federal guidelines, the states have to take on responsibility. It just is what it is. I would say that the AI enhances rather than replaces the human oversights, and we need to find complements there.
So Matt, I see you had something you wanted to say about interstate interoperability.
Awesome topic, but maybe off course from the AI. That's a hot button for lots of people. I would think that in healthcare we would love to say interoperable, but there's a lot of safety stuff that we have to manage and cyber things that we have to manage within the healthcare space that I believe is different than the industry space. So that would be, James, my only pushback to you would be, I actually don't think this ought to be open in healthcare. I don't think there ought to be a lack of regulations. I actually sort of side a little bit more with Zach's. In the interim, unless there's a federal policy that says, here are the things you do, it's incumbent on us as I'll call it a higher order. I don't know what the right answer is, but I believe the government and healthcare both have a responsibility to our patients and our constituents to make sure there's a rule set there. Otherwise, it's going to erode the faith. And that actually is detrimental to our technology. Like, it would be great to see AI do wonderful things. We talked about that this morning. We talked about that, I suspect, the rest of the day, although I missed it. I wouldn't want to see that take a few steps back. Like, this shouldn't be a 2 steps forward, 1 step back process. This should be a forward, 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 forward. And unless we have the right regulations and safeguards to make people feel good about it, I think we're out there in no man's land. So it's not like open source coding. You can do whatever you want in your own garage. This is about healthcare, people's protected health information. It's very important to them. And I think we have a responsibility to own that. And in the same way, that's some of the pushback when you hear people like Judy Faulkner talk about interoperability at the highest level. There are worries that that information is misused. So as long as we have protections, which I think what you're talking about, we could be able to rocket forward, and then we'd all be happy.
I think that's an extremely important comment today, as we're seeing access to everyone's data, whether it's healthcare, personal tax, or whatever, being taken by a select few today. So I think privacy, you're absolutely right, whether it's healthcare, personal tax, or your social security information is paramount to most people and something we need to consider. Thank you. Sean, you are a resident economist. Tell us what your opinion is from your perspective.
Sorry.
We can bring out the drinks if you go too long.
1 second, great. So let me start. So, yeah, I want to back up. One thing that our lab's been interested in is kind of like how looking at digitization of healthcare in general around the world and in North Carolina and different places. And one thing that, we kind of see, so I always show this graph when I give a lecture that's like the technology frontier, right? So it's like, and I label like these curves that look like that. They're like iPhone 1, right? iPhone 2, iPhone 3, right? And, we're thinking about like, in the US healthcare system, right? We've kind of started on the iPhone 1 version and we're following a path, right? That's hard to get off of because there's a lot of path dependence in healthcare. I don't know if you guys knew that, like we still use fax machines, right? So that's an example. And then, but you have a lot of places in the world, like, like I work in Kenya, right? Like go there and, I went to 5 hospitals last time. That were like digitizing in the moment, right? With different vendors and trying AI and all of this stuff, right? And it's, for better or worse, right? They are like moving forward, implementing innovative tools, right? And we need to learn from those implementations. The innovation is happening here, to be clear, right? But the implementation is happening elsewhere, right? And part of that's because of the nature of our healthcare system. But the important piece for us, I think, and for those for the whole world, right, is that this is kind of an inflection point where we need good research, we need evidence, because that's going to set us on the next path, right, going forward. And so the implications of what we do now are pretty substantial, right? If you think about the lives impacted over the course of the next 100 years or so, right, or more, right? And so, what I feel like we need is, investment in like good research that kind of goes in part like looking at the engineering pieces, but also going beyond that, looking at, impacts on patients and the health outcomes that we care about and the efficiency of the system and the costs and all of that. Same way we evaluate drugs, they're like proper randomized trials, right? And experimental methods to identify causal effects of things. And right now we don't have there's not the funding or the guidelines that are creating incentives to do that, right? So now we're just kind of trying stuff and hoping for the best, and we don't have the infrastructure to like learn whether that's having a benefit for patients or is cost effective, right? Which seems nuts to me that we're kind of treating AI, which is probably, having a larger impact on patients, right? If like you have a decision support system that's adopted in a system that might have a bigger impact on patients than any drug, right? Or any single intervention, because it's affecting decisions directly and the information that you have access to and how that's presented, right? And so like, there's just so much uncertainty. And the only way you can deal with that is by, partly, make sure the data is good data, representative, high quality data, and it's representing the patients that you serve, right? And then, but then also going beyond that, making sure all of the, the algorithms are doing what they should do, data drift is in check, but then like, there's also a human factor on the other end. You can have a perfect algorithm, right? But then, the impacts on patients and, doctor decision-making, right? As they use these AI tools, like there's so much we don't know, right? And so, I think, research funding is important and the incentives to do that, right? Whether it's, I think ultimately it has to be at the federal level. I mean, state level regulation in long run doesn't make a ton of sense to me, but state level regulation can inform those federal regulations. And I think North Carolina can serve a big role there, right? Given the ecosystem that we have. So that was not 28 minutes. Sorry. That's right.
So research has found, and this has been, they keep telling me, oh my family always says you can hear me anywhere. Okay. Research has found a deteriorating lack of trust in the doctor-patient relationship, which has driven patients to turn to TikTok. Who uses Dr. Google here, right? Dr. Google and other online platforms for medical advice. You might argue that while this democratizes access to information, it also increases the risk of misinformation and can have potentially disastrous consequences. We've seen this in particular in the vaccine space today as a pretty glaring example. With this backdrop, gentlemen, patients are starting to turn to using AI medical tools for diagnosis, their own diagnosis. Don't you have that friend or your Uncle Charlie or Aunt Sally who tells you what they have because they've gone to Dr. Google and they're certain that they have this disease? For diagnosis, treatment recommendation, and second opinion. So my question to this group is, how will these AI tools impact the trust in doctors and other healthcare providers, particularly if Dr. Google or Ms. TikTok disagrees with your position? So with that, why don't we begin with our doctor right there?
To be the doctor. It's interesting. The last meeting I was on was with two other physicians who are both informaticists, all of us in different board specialties. And we were talking about open evidence. So open evidence is an AI tool set that is pointed to the medical literature. So why wouldn't we want patients to be there? Why would that be a problem? If everybody's gone to their primary care physician in the last year, and of course you should have. Rough ploy. I mean, trying to get some makes it money here. No, if you've gone to your doctor, you realize that they spend about 10 minutes talking to you, and the entire interaction is probably under 20, unless you've got a different relationship with your physician or your concierge practice where they've guaranteed that they're going to spend an hour with you. Let me know where that is. If you go home with an issue, it's very likely if you had the right tool set, you would spend a lot of time working on your issue. And if we can get the right tool sets and train the AI to deliver the right answers, or at least most of the right answer, the next visit to your primary care physician would be very meaningful. Hey, I didn't go to Dr. Google. I went to where you told me to go. It gave me these possibilities, and it matched completely what you told me. I love you. You're my best doctor ever, right? That's most of it, you would hope. Or you might come up with something that says, number 5 on the list that I found really concerns me. Can we talk about that? And now your 10 minutes is spent dealing with the issue that's important to you. And I think we talked, and I don't see her, but I think we talked about that earlier in the morning around sort of personalized care, even though it doesn't take a lot. It's a very simple interaction. So I'm not opposed to Dr. Google, but I kind of am, but I'm more opposed, or I'm more interested in trying to target the right sources and the right AI tool sets for patients to use and get them to move away from the wrong ones. I just got a text message that said I owe a bunch of tolls. Has anybody gotten one of those? Okay, so yeah, exactly, right? Right. So Jeff Jackson's telling me, I got to do this. You're going to listen. If your doctor says, hey, if you have questions about this or you're worried about something, go here and play around next time and send me a message, and then I'll try to get back to you. To me, that has value. Now, in that sense, I do think we need regulations on those tools. They've got to be highly curated. They've got to be based in fact. They've got to be funded and supported in the sciences. I would not be political, but they can't be influenced by politics to some degree, because I think that has inherent danger. Doesn't matter which side of the world you're on, it's still a little bit iffy. And I think that would actually bring trust to the AI healthcare ecosystem.
So how do we find those places that you can get that very good information? I just want to use a personal experience. My husband was diagnosed with lung cancer. His surgeon handed me a booklet and pointed out on the last page, these are all the websites you should look for information on lung cancer, ignore all the others. That made a lot of sense to me. It was printed in a book from Georgetown University Hospital, leading hospital, had it all there. that I took that. You don't always get that information. So we talked about curating it. Who should curate it? It doesn't need to be political. How do you get it out there? How do you know the good ones that are true and the ones that aren't? Scott, you look like you have something to say.
Cue that up real quick. I've read somewhere around 11 or 12 AI books for educators since summer before last. I teach abroad in Austria and in China, and wanted to look at some of the ways that they were using AI in education, which I think is easily scalable into healthcare, any really of the public services. With that being said, as we know, most artificial intelligence is only as good as the prompt that you give it. So with that being said, I don't really feel that it's a who should be doing it, but a how should we be doing it. When it comes to who the right person is to put it in press, if we're talking about a national order of some sort that says this is the right way to prompt with regard to HIPAA, with regard to the PII, PHI, that's all fine and well. Because I have a little heartburn with the HIPAA side of the world for the fact that at the Revenues Collection Management Conference last year for HFMA, everyone was talking about the utilization of AI. We have no problem applying it in healthcare for the financial side, but we have a huge problem with applying it for the health side. Makes no sense, because I guarantee you I care more about my finances, knowing about that, than knowing that I'm a type 1 diabetic. Just not real worried about that. So at the end of the day, those arguments are always going to be there. If I were sitting in Zach's chair, yeah, I would probably care a little more about, per se, my mental health awareness, things along those lines being publicized. So we need to stay strict with the laws and rules that we have. But I think the application of artificial intelligence needs to be educated all the way down to the middle school level, so that we have some of those foundational pieces that are incumbent upon the morality and ethical sides that we really worry about.
James, what do we do about the issue using these apps of hallucinating or drift? So how do we know we're not getting some crazy something or other that we now waste our precious 10 minutes, Matt, that we have with our PCP to talk about what really was some hallucinating thing that we got?
Yeah, I mean, I'll start by saying, don't use ChatGPT and Claude for your medical information like that. They're not.
I mean, who agrees with that? Raise your hand if you agree with that, not to use it.
I have a lot of friends who are just like, I do not care. And they'll just upload everything and ask you questions. And yeah, it's a massive problem, right? People are going to do it. People are going to do it anyway. And that's why I think there's a massive need for large knowledge bases that are secure and verified by the right medical people to aggregate a bunch of information and then be able to query and ask questions against it, right? Like not use these off-the-shelf tools, which none of them are compliant. Like I think that's a big startup need. I think people should be building these knowledge bases. I mean, we're all using the same models. Like we're all going on Hugging Face and choosing a model or building some integration with Claude and with OpenAI. And so, it's less about the algorithms and the actual models, and it's more about like what data you feed it. Like it's, good data in, good data out. And so I think that's the moat, if anything, to build really secure and verified and vetted knowledge bases. And that will help with the spread of misinformation, but it needs to be regulated by some body inside these entities, some type of peer review, something, in order to make sure it's factually correct. And then also, have like a human in the loop that if somebody asks a question without sharing too much information, be able to, go search the web, answer it if you can, and then, make sure that was correct, right? And make sure it doesn't hallucinate, have some board put a thumbs up or thumbs down. If it's thumbs down, it's removed from the knowledge base, So I think there's a big startup need for that.
Right.
So we have a little startup called Collective Good, and the idea was that we need clinicians of some stripe in the loop in the whole process for validating clinical AI models and building that knowledge base that you're talking about. I think it's not just a knowledge base; it's a kind of a causal mapping, right? That you need, right, to really have high quality AI that guides that clinical decision making, right, in some way or another. And so that's kind of what we're trying to do is, one, keep clinicians employed because they're people too, right? But we want to kind of make sure that we have, so we're using kind of collective intelligence to validate like these clinical AI models, right? But I think things like that are, keeping human decision making in the loop in some way And it's not just it's not like humans as a stopgap. It's like humans in the loop and using that knowledge at least as a benchmark, right? So AI might get better, but you need some sort of benchmark to make sure that it's not going off the rails in some way, and it's kind of aligned with our values and, I think medical practice in some way.
Matt?
So this may shift the gears completely, but I think on all of our roadmaps in the healthcare AI space is this idea of autonomous primary care, right? So that's completely different than what you just said. So now you're talking with an AI-enabled chatbot that's actually going to give you advice and maybe titrate your medications based on a series of data that we've collated and said, this one's okay. Does that need regulation? Does that need some oversight?
Okay, let's pause. That's a really, really important question. How many people think what Matt just described, which is on the roadmap, needs regulation? Raise your hands. It's late in the day. I don't want to make people stand. Good. How many people think you don't need it?
So I would push back and say that you already have it. In what world did we not use empirical evidence and data to make those decisions, you and I independently? Now we have something that aggregates that information, pulls it all together and spits it back to us. Why is that any different than me doing months and months of research in advance to have an argument with you one-to-one? Now we have that ability to take that information with the right prompts, with the right receptions, and find out what empirical evidence is truly speaking to. So if I'm having an argument over an endocrinology situation here in New Orleans, and I wanted to draw upon Dr. Ramona Granda, who retired 20 years ago, and I want her information, I don't have to call her on the telephone. I can pull her information right up on ChatGPT, aggregate all of it, and come up with a synopsis. I struggle with the concept there.
But you go to 5 endocrinologists and you get 5 different opinions, right? It's about the variability. And like we ran this like little experiment with ChatGPT, just giving it clinical vignettes, but then toggling the parameter values of it. And you would be, everyone do that experiment, you would be shocked about the variability you get. And it's like, how do we know what's right and what's not, especially
You may get that variability with 5 physicians.
Yeah, right.
Oh, there's definitely research where you do get that variability.
And
But
then you use AI and then AI plus a physician or a physician alone. It seems that the AI has started to perform as well or better than the physician.
Well, but not 5 clinician opinions that are appropriately aggregated, it turns out. That's what the research is saying.
Google's Amy outperformed physicians 78-1
It's true.
For what?
on diagnosing. They ran it for 18 months and it outperformed every physician it went to.
Every clinician from a representative sample of clinicians that
70
people go to see of
Yes, sir.
a representative.
But I think
But
that's
it's
the
like,
point.
but what is the one, what is the benchmark? Right? And 2, there's not one single right answer is a problem. It's like, there's so much variability in all of our health needs, right? And there's so much variability in clinical opinion, and it's a probabilistic exercise. There's not one right answer anyway. And so.
But I'll go back to endocrinology. A 34-year-old endocrinologist at the VA sees me once, 4 times a year. And you're telling me that variable statistic of their decision making has a higher power yield than the aggregated one from the machine?
No, I'm saying that you go to multiple clinicians, right? I'm saying that the AI may be better, right? Then it's going to be better than the average clinician, right? Or some proportion of clinicians over time, right? You have a distribution. And to also the aggregate opinion of multiple clinicians is going to be better than the individual clinicians, right?
The issue here is that I think you're both saying the same thing in different ways. And generally the studies have been on, and I forget the name of it, somebody help me, the 102 cases that are really difficult, right? And they're challenging the computer to against William Osler's brain, right? And he's long dead. But the reality is when you see your endocrinologist and everything's good, there's one answer: stay the course. If everything's not good and your blood sugar is a little too high, we know what the answer is there too. I mean, we got to get your blood sugar back down. If you have an ear infection, in most places, maybe not the US, it's generally a virus. There's one answer. There's some things that are very binary and very simple that take up a tremendous amount of patient's time, physician's time, overhead, tremendous cost. It's 18% of our GDP. We've got to get that down somehow. And so if we look at the things that are actually pretty easy, we could manage a ton of this with AI. The question is, we've got to be comfortable with it. And I think that's actually the basis, Zach, of where you're going, which is if we have the baseline regulation and we control it, as you said, I think with the thumbs up, maybe that's the right place to go. That's what I want to do, is to see us move one step at a time, as opposed to throwing all of medicine to ChatGPT and sort of debating whether it's good or not. Like, we're going to lose that. That's a gong show.
At least efficiently allocating the clinical resources we have.
Well, I think that's an interesting situation on the easy cases, but what about the difficult ones? We heard some really good discussion today about bias. And how do we do when you're dealing with AI or autonomous AI? We've seen lots of studies that women's complaints over the years get ignored. And they were told over and over it's some psychosomatic disease, and then disease is ignored in their state. So what is AI doing in that area? Listening any differently from certain groups, such as women or others, that they're not, their physicians and their primary care doctors are not listening to them?
I think there's just like an overall issue with women's medicine in all of healthcare. Like from what I've started to realize just from talking to different doctors and stuff, I think men were mostly studied when creating a lot of this medication. So I think it has less to do with AI and more to do with there needs to be a data set of proper research on women, and then you're able to use AI to accurately use it.
No,
Good way, Zach.
yeah, no, I'd agree with that. Especially for subsets of women who, especially in birth rates and in other areas of healthcare are not listened to. And so I do agree that we just don't have the data sets in America. We don't have the type of rounds and for a young physician to go see all of those different types of women, to have experience with those types of women. And we don't even have hospitals dedicated to making sure that we are looking at those who have low health outcomes. And so I think that we have to build the infrastructure, and then AI absolutely can take that data and be a driving force in making sure that not only, as the doctor said, that they can, with regulation, and start to make their doctor's office visits more productive. But there's just a baseline for everybody to learn from, because if it's just not in your experience to deal with those who have high morbidity or again other health outcomes, if you don't have the data, then you can't manipulate it, and you can't make sure that very easily we can think about a pathway forward. Otherwise, it's stuck in the research papers. And nobody's really applying it, which they should, by the way. They should be taking that and applying it, but America and North Carolina have just shown that they have not.
So I'm going to throw the doctors. Who are the doctors in the room? Good. There's a couple. We do have the data. The doctors aren't good at this. When we listen to people who don't look like us, whether you are Black, female, handicapped in any way, there's a bias that we bring to that examination room that we understand, we have studied, and it seems pretty clear. We're not that good. So I actually think that the future of AI is really helpful, because if we can create an unbiased listener and apply it without the bias of whatever you care about, race, gender, religion, sex, it doesn't matter. The science is still applicable. It's the human interpretation of the human condition where we twist it around and then inappropriately apply the science. And we've got tons of cases like that are throughout the literature. As an academician a while ago, before I moved careers, We would always tell people, like in emergency medicine, chest pain is a very common complaint. It's actually pretty boring, joking about that earlier. If you go in to see an African-American female and you don't understand the literature and you aren't aware of that bias, you can make a mistake. And so we would teach, hey, you're going to go see that woman. Make sure you know that across the board, people blow their complaints off and their outcomes are worse as a result. Don't fall into that trap.
Does it work?
Got it? And the resident would look back and go, okay. And they would go and they'd be very methodical and they would think about that. And it's in that kind of teaching that we try to make doctors better. I think AI can actually get rid of a lot of that.
Great.
I would agree with that. I think, you know, there's like some very interesting studies that you're probably referring to with, they do like audit experiments, right? And it's looking to see like, okay, what is the effect of say race or gender or some other identity measure on like your clinical outcomes? And it's pretty clear, like, it's not good, but then you know what like those biases are, right? And theoretically, like the AI could help, you know, kind of train away from those. Because I think, you know, most clinicians, right, are trying to, like, it's the subconscious, most, right? And so, right, and so that's a challenge. I wanted to say one kind of controversial thing that like you're probably going to disagree with as a chief of, but I don't think we have like, yeah,
Go for it.
I don't think we have like any good data for training clinical AI models. Period. Right. So all of the, like, if you like look at the what's being used to train these models, EHR data. What is the EHR data collected for? Billing, right? It's not collected for and that influences what's collected, right? And who it's collected on, who shows up to a hospital, right? Are the people that show up in the data set, right? If you were going to build the perfect data set to train clinical AI models to guide decision making, that's like not how you would collect the data. And I haven't seen any like efforts to really collect that representative. Are you gonna say something? Right, because I think that would be great. Like, but I think that's a problem, right? Is that the bias in the data we're using, right? Not just that, but
Scott, and then we'll do a lightning round. Okay.
A massive healthcare system. A few months ago, when we looked at sort of 10.8 longitudinal records, 10.8 million longitudinal records. You may not have the data set,
no, it doesn't.
but
matter.
I do.
It doesn't matter how much data you have. It's how good the
350
data
million
And it's-
is the number I'm looking at.
It doesn't matter how much data you have. It's the
Who would opt
quality of the
into a
data
Commonwealth
and the
for that data.
representativeness of the data, right?
I mean, the good
See what
news
I'm
is,
saying?
yeah, I do.
Okay.
But when you clean it all up,
Yeah.
and you normalize it to the best of your abilities, and
You still are not catching those people who are not showing up at your hospitals, and you're not adjusting, you're not measuring the things that
You're right. You cannot collect data on people that don't
don't
show
show
up.
up, right?
But if you collect data on all your ambulatory, surgical, and hospital visits,
For the purposes of billing.
it's actually for the purposes of
right?
total healthcare. So like we have,
No, but
all
like
the
its
data.
influence, let's be honest, it's collected mainly for billing purposes, right?
I
Yeah.
would say originally back in the 70s, that's correct, but not now.
Okay.
I mean, I think we collect all sorts of stuff.
Yeah, I would agree with that. I mean, we got away from fee for service 14 years ago at minimum. 350 million users is what OpenAI is hosting right now. That's globally. If we were to talk about an open commonwealth, something that every person that signs up for that platform, be it Meta for Facebook, be it OpenAI, whatever you want, and we're agreeing to share that medical information, just like we agree to share our fiscal information every time we log on to Link or any of the other ones that are out there, and they share them across the retail boards. There's nothing stopping us from aggregating that information. It's a matter of big ticket regulation at the federal level. We all know that. And it's a matter of companies like yours getting together and deciding how we're going to work interoperably.
And that's one thing, if I can hop in. Okay, yep, a few things, lightning round. That's why we're starting the AI task force. So the governor is going to do an executive order for that purpose, for this kind of conversation. Because again, as legislators, we don't know what we don't know, but we need to build the infrastructure so that we can have these discussions to co-guide, right? To co-lead this together. These are conversations, you're doing it every single day. We have Duke Health, who is a founding member of the Coalition for Health AI, right, which is a sort of a national piece to help make sure that data privacy, where we get our data sets, making sure that patient data is safe. Like those kinds of conversations are what are going to make North Carolina, I think, a really good place for regulation, but also for building the ecosystem that's necessary to make us a leader. And that's really what we are excited about. I had dinner with I think it's the North Carolina AI Tech Policy folks that are out of the Triangle. And we want to send the bat signal to the rest of the country that we're the place where we will invest. We will be we're open to dialogue and back and forth. And we're a place where we have the talent pipeline to get it done too. And I think it sends a signal to the VC community that we're somewhere that, hey, if we don't have it, you can invest in the company to help build what we don't have, right? Very similar to what they've done in Silicon Valley. A few highlights that I think, and this is because Duke Health is in our backyard in Durham. Duke Health is working with SAS to expand capabilities and operating efficiency. They're trying to build ethical models for data-driven decision-making. One thing that we're excited about, but I think takes some more conversation around patient data and privacy is when a doctor is in the room with a patient. AI can record that conversation and take a lot of time off of you having to go in and take notes, right? That's just a proposal and some things that they're researching to see like what is the downside? Does it actually save time? But it's thinking about the ways that we can make healthcare more efficient. North Carolina is towards the bottom of the country in healthcare cost. So when you said that we have to bring those costs down, that is absolutely what we have to do. And I think that AI is probably one of the main drivers for making sure that there's better time used with patients and doctors, but more ways for them to save money on unnecessary visits. And the way that we are sort of billing insurance and those insurance costs. And so there's so much that's happening that I think in North Carolina, do know that the state is behind you. Do know that the state wants to be the place where your innovation, your smarts, and the rest of the country sees as, I think you said, the new frontier, Sean, literally the new frontier in the healthcare space, because we have UNC Health, Duke Health. We'll have the North Carolina Children's, which will be the largest children's hospital between DC and Atlanta that's coming to the Triangle. We have Novant. I mean, we have all of the aspects. And that's why, again, this task force and some of the work that we're doing in collaboration is going to be so critical. So thank you for letting me in. But I think this is, I might nominate each one of you to be on this task force.
There you go. So real quick, we're going to do a lightning round, 10 seconds each. Each person we're going to start with you, Sean, to my left. What keeps you up at night? What gives you hope? Can't be more than 10 seconds, so go. And what gives you hope?
Just the amount of innovation and creativity that you see, and the willingness to try this thing, right, and make sure it works. And I think we're focusing on the right things, right?
Thank you. Matt.
Cost keeps me up at night. Great tools, but they're very costly. So that's the only thing I would keep me up if I was kept up at night, which I would. I think that we are actually in a position now that in the next 5 to 6 years, we're going to radically change the way that we deliver healthcare using AI. And that isn't seen very often. We've seen medicine change in small increments, but I think we're ready to make sort of a major shift, not a drift, but a major shift using AI in the way we deliver care that will hopefully be better for patients. I truly hope so.
Great. Thank you.
Yeah. What keeps me up at night is cost, but most importantly, the number of people who don't have access to care. That keeps me up at night, because if you don't live in an urban area, you are in a desert, especially when it comes to specialists. What gives me hope is I think what AI can do for access, what AI can do for diagnoses, what it can do to bring down costs, but most importantly, what it can do to allow those who are in the 8th grade to believe in a future that's greater than what we have right now. And it takes these kinds of conversation investment by the state to build the type of ecosystem that creates AI hubs across North Carolina that allows us to be one of the leaders in the future.
Great,
Um,
thank you, James.
I think software engineering is being commoditized and we're seeing a lot of these tools being able to write code, but I also think it's contributing to tech debt and building bad code that's being shoved into systems and people don't know how the infrastructure and architecture works. I think I think I saw stats like 41% of new tech debt's gonna be contributed by AI. That definitely keeps me up at night. And then the part that gives me hope is I love how every department and every business is now in the AI conversation. Like our company used to just work with the product teams and engineering teams at different companies. And now we're talking to the sales teams, we're talking to the finance teams. Like I find that very exciting. And now everybody's in the conversation instead of just being like siloed to the engineers of the world. So it's pretty cool to me.
It's great. Take it home, Scott.
I think what keeps me up at night is modeling leadership for the leaders of tomorrow from what we have today. And what keeps me hopeful is that generation of tomorrow's resilience, their ability and thirst for knowledge.
Well, a great way to end. Please give a very warm round of applause